Hello, everyone. Thank you for joining us for today's webinar, Creating Joyful Long-Term Care Homes, the Ireland Experience, co-hosted by Family Councils Ontario and CARP Ottawa. My name is Taeyang Jung. I am the event and project manager at FCO. Today's guest speaker is Anne Coyle, retired health professional and advocate, who will be introduced by Kathy Wright from CARP following my short introduction. So before we start, I would like to take a moment to recognize the land on which we are gathered today. We're meeting on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We wanted to share a few logistics and housekeeping rules before we turn things over to my co-host, Kathy. You'll notice that all participants are in listen-only mode. We have reserved time today at the end for an interactive question and answer period. At that time, we invite you to use the Q&A box to ask your questions to the guest speaker. You can use the Q&A box throughout the presentation as well, and we will address the questions at the end. And if you are experiencing any technical difficulties, you can write that in the chat feature, and I will be overseeing those. And also for your information, today's session is being recorded and will be made available to everybody on Family Councils Ontario's YouTube channel next week. Now it is my pleasure to turn things over to Kathy Wright to introduce our guest speaker.
Thank you very much, Taeyang, and thank you to all who have joined us this afternoon for our last Lunch and Learn webinar of 2024. We have very much appreciated our collaboration with Family Councils Ontario this past year, and would particularly like to thank Sam Peck and Taeyang for all their support. We look forward to another positive year in 2024. So for those joining us for the first time, I chair CARP Advocacy Working Group on Long-Term Care, a group with representation from Ottawa, Niagara, Hamilton, and Mississauga. And we collaborate with like-minded organizations in Ontario with a goal of influencing change in Ontario's long-term care homes from institutions to homes. This means transitioning from the traditional institutional, medical, and task-oriented model of care to a person-centered approach. Although we do have some innovative homes here in Ontario and other parts of Canada, we are way behind most of the developed countries that have already made this kind of transition for those requiring long-term care. We hope our learnings today from Anne will inspire us to take more action to make this change a reality. If you'd like more details or interested in helping our cause, you can visit our website at www.changeltc.now.ca, where you can find the recordings of our webinar, as well as details on the various innovative approaches to care. And now I have the distinct pleasure of introducing Anne Coyle. Anne brings extensive experience in innovation and change management and is now focusing on projects aimed at redesigning policy and practice in nursing homes and supported housing for older adults, with a focus on technology supports. Her end goals are the same as ours: to shift from traditional institutional nursing home settings to home-like community integrated models of care where residents can thrive in a more personalized and joyful setting. And thank you so much for taking the time to be with us today, all the way from across the pond. And the mic is now yours.
Thank you very much. Kathy, that's great. Am I in? Am my screen okay now? Okay. Okay, thank you very much. And thank you, Kathy, and hello, everyone, and good evening from Ireland. It's 5 o'clock in the evening here, hence I have the lights on. I'm very pleased to be here today to talk about my favorite subject, which is to transform Irish nursing homes into places for older people. And as one of my colleagues is fond of saying, our future older selves can flourish. So before I get into talking about a little bit about how we've developed in Ireland over the last few years, or not developed in some ways, I would like to tell you a wee bit more about myself in relation to how I got into this whole area of promoting change in long-term care. As a young occupational therapist in the 1980s, I worked in a large psychiatric hospital, which on the one hand was to the fore in the decongregation movement that was going on at the time and was seen as a very exciting place to work. And on the other hand, there was 2 wards, as they were called then, where there was about 40 people, older people, mostly who had dementia, were living. Now, this place or these wards were seen as a very unattractive place to work. They certainly weren't career promoting in any way. And the nurses used to tell me that they were often where you were sent to work if you were seen as in any way being troublesome. The institutional practices and cultures that were often shocking and aligned to what the famous sociologist Irving Goffman described as total institutions, whereby all aspects of a person's daily lives were lived under one roof. So seeing how low down the social scale that these folks were, this had a profound impact on me, and which I carried for the rest of my career. At that time as well, I suppose I had the same experience as a lot of other people, in that my mother, who is here, you can see her here, she's the one in the middle, lived with dementia for 10 years. This is her with her 2 sisters, who, along with 2 of her brothers, out of a family of 11, lived with dementia in their latter years. What I found deeply uncomfortable and troubling was squaring this personal experience with my much loved mother, but then going to work every day as a healthcare manager, hearing about and speaking about cohorts, beds, dependencies, deficiencies. And what was probably worse was regularly hearing the language of person-centered practice being used, often when it was a long way away from what I was seeing on the ground. There was a wonderful Canadian researcher called Dorothy Smith who coined the phrase bifurcated consciousness, which for me, when I came across it, was a good description of how I've been feeling trying to carry these 2 different identities at the same time. So while moving away from my personal why, let me just tell you a little bit about the Irish context first, in general, and then how it relates to long-term care. And just to say, I might in this presentation to use the terms nursing home and residential care, long-term care interchangeably, but they mean the same thing essentially. So let me just tell you a little bit about Ireland. We're a small country in the northeast of Europe with over 5 million people. Population-wise, we're a relatively young country in comparison to, for example, our colleagues or our neighbours in Italy or Germany. However, as a nation, we are rapidly catching up. For example, the number of older people over 65 is set to double over the next 30 years, while the number of people over 85 is set to double over the next 20 years. Economically, we're in a relatively strong position with almost full employment. However, we still have a lot of struggles with health and social care and housing, and we're losing many of our young professionals, such as nurses, doctors, and teachers, to other countries such as Australia, where working and housing options are perceived to be better. Overall, the stated policy in respect of older people is to support them to remain in their own homes for as long as possible. And to be fair, the health system does its best to honour that, notwithstanding we have problems with a supply of home care workers. Ireland has approximately 40 places per 1,000 for people over 65 in long-term residential care, which is lower than the European average. And we also have a very significant gap between home care and nursing homes, with very little housing with care, mainly because we don't have the support structures in place, but also we don't really have a culture of right sizing in this country, but that is beginning to change, to be fair. In terms of long-term care, up until about the early 2000s, nursing home care was primarily delivered by the public sector and religious orders, with a few small private mom and pop nursing homes. A lot of these were large geriatric hospitals, as they were called then, or county homes, which in effect were repurposed workhouses and some smaller, more modern 50-bed place buildings reasonably well located in small towns and villages throughout the country. This is completely reversed over the last 20 years. And what we now have is 74% of the nursing homes are privately owned, with a dwindling public and voluntary sector. As well as that, and is the case across many countries, over the last few years, we've seen a consolidation of nursing homes, with the vast majority of private nursing homes in Ireland now owned by 15 large corporate groups, many of which are owned outside Ireland. And like other countries, we've had closures of small nursing homes, particularly in the smaller towns and rural areas, and the development of large nursing homes in our bigger cities. We have a fully across the board regulation process, which was introduced in 2007. And I think it's important to acknowledge the positive impact that this has had in improving the standard of nursing homes and removing many of the institutional practices that had existed at that time. As with many other sharp policy changes, it came about as a result of a scandal in a nursing home called East Cross, which came about through an investigative journalism program. And this led to one of the two major public outcries we've had in recent years, the other one being COVID, which I'll talk a wee bit more later on. And this saw the introduction of an independent regulatory system. In 2022, we saw the first national survey of nursing home residents and families, which I'll come back to later. And more recently, we've seen the long-awaited Assisted Decision-Making Act finally commenced in 2023, following relentless advocacy and activism, spearheaded by a wonderful advocate called Patricia Rickard-Clark, providing a much-needed decision-making support system for people who lack capacity and replacing the existing antiquated system that was in place. So our Canadian listeners might be surprised at how recent some of these changes are. I know many countries have had these kind of surveys and legislation in place for many years, and we're very well aware of how behind the curve we are in relation to some of this. So while thankfully we have moved away from the long crowded geriatric hospitals, one of my colleagues used to talk about the long Nightingale wards where the residents' beds were so close together they could hold hands. Thankfully, you know, we have moved away from that. But I think for the early 2000s, I suppose, there was a big focus on quality of care. To be fair, it was probably what was needed. You know, issues like continence care, preventing falls, infection control. So there was a lot of focus on improving these issues. So what happened, obviously, though, is they followed the structures of the acute hospitals. You saw nurses' stations, ward rounds, drug trolleys, all of the artifacts that point to, you know, focusing on dependency and decline and illness. Food was still prepared and still is prepared in central kitchens, and long corridors still exist and are even in the most recently built nursing homes are very much the norm. So while all of this was happening, while all these changes of ownership were happening and the introduction of regulation was going on, conversations began to emerge about things like person-centered care and quality of life. So for me, personally, a study trip to Utrecht in the Netherlands in 2005 was my light bulb moment. And it was my first time ever to experience the small household model, where 6 older people with dementia lived together in a household, still within the confines of a larger nursing home. The households opened onto an internal covered courtyard, and this courtyard was like the town centre with a coffee shop and a shop where residents and staff went to get the groceries for the house. There were no obvious clinical artifacts, and on the second floor, there was private retirement apartments. I think this was the first time that I truly felt I understood what person-centered practice actually looked like. I wasn't alone in my thinking. Usually is the case when you start out on a journey of change. You know, I found my tribe, and in this case, Professor Brendan McCormick, who's now a global leader in person-centered care, was at the time leading a countrywide practice development program with a bunch of deeply committed nursing leaders. We found ourselves also connecting with Steve Shields and Lorraine Norton from Culture Change Now in the United States. and we used some philanthropic monies to have them come over and do some workshops right across the country, which inspired and agitated people in equal measure. Their book, In Pursuit of the Sunbeam, still inspires me today. The other key influencer at the time was Dr. Bill Thomas, who developed the Eden Alternative and the first greenhouses, and David Shearard, who developed the butterfly model in the United Kingdom. Aside from David's work, which of course was in English, but it wasn't open source, and because Google Translate didn't exist back then, it was quite difficult for us to get our hands on other European literature, such as was emerging in Scandinavia and the Netherlands. For this reason, we leaned in a lot into what was happening in the US, and to be honest, we got quite a bit of pushback from people in relation to it, the main criticism being that Ireland was seen to be culturally different. So for this reason, we developed our own version of the household model called the Tyloch model, Tyloch or Chyloch, depending on what part of Ireland you're in, which roughly translates into the heart of the home. So I think you'll probably recognize that a lot of the principles are very similar to what you'd see in other household models. So a shift from task-oriented institutional model to one which supports older people to continue to direct their own lives at home within a nursing setting. The nursing home must become home in all respects, not homely or homely, not home-like or homely, but home. So we had endless debates about the philosophy of this, whether it's truly possible to create a true home when it's not, in many cases, the place of your choice or imbued with the memories or rituals of your own personal narrative and life. The nursing home is divided into domestic style units. At the time, we didn't set out a defined size of a household, mainly because there was no consensus internationally. What's happening to me here? Hold on. Sorry, something coming out of the way. So like we were seeing in the Netherlands, there was households of 6 and 8, and in the States at that time we saw numbers going up to 16 or 18. In hindsight, I wish we had become more directive, as our own public service guidelines for traditional nursing homes started using the language of households for 25, which was far too large. The kitchen and dining room becomes the central focus of the household, and every effort is made to include the residents in the rituals of preparing and eating meals. This, like every other household innovator will attest to, sparked many conversations about risk, food safety, organisational efficiencies that still go on today. But most of the myths and barriers have largely been addressed in no small way by the support of the regulatory folk, who, from what I've seen, have been very supportive and encouraging. Residents make most choice about their daily routines. This probably sounds very quaint now, but not that awfully long ago, we were having discussions about residents not having the choice about what time to get up or what time they went to bed. And each household has dedicated staff that work almost exclusively in the household. And I'm afraid this probably is still quite aspirational, given the many challenges we have of staff turnover here in Ireland, despite the fact that we know that consistent assignments actually improve staff retention. Okay, so I suppose, to be fair, there was tacit acceptance of the principles, and we did make some progress around a number of elements, which I won't really go into because I don't have the time, but it would be fair to say that they weren't universally adopted in the system, which was consumed by the economic crash and changes of ownership in the private sector. While it is, to be fair, the regulator did drive changes in relation to developing a social model of care and more homely environments, as did the professional education bodies, such as the nursing and midwifery development units. But the system continued to be dominated by task-oriented practices and larger congregated models. As such, I think it's fair to say it was a nice to have rather than a must have. But like everything else, there were a number of early adopters who forged ahead with new developments, despite not having the structural system behind them. I'm going to show you 3 examples that I'm close to. There were many, that's not to say there were others, there were many other pioneers and committed individuals, such as Michael McCoy in County Louth, who pushed ahead with innovation and change regardless of the challenges in the working environment. The first one is one that I was personally involved in. This one was a replacement building for what was known as the dementia-specific public nursing home. At the time, it was permissible within the public system to develop small units of 10 with residents with dementia. We used this guideline, and together with an oversight group of advocates, academics, health professionals, senior managers and family members, we developed the tree house collectively known as the Village Residence in Drogheda, County Louth, which is just north of Dublin. As the building developed, we had positive engagement with residents, staff and the local community. Each house has its own front door, a communal kitchen, living, dining area, and as few institutional artefacts as we could negotiate. And most importantly, it was underpinned by, very clearly underpinned by an ethos of human rights. We didn't get everything we wanted, because it is a public facility. Despite many robust debates and discussions along the way, we didn't have a complete free rein. For example, within the open plan kitchen area, the kitchen is partially closed off more than we would like. You can see the yellow wall there, where we would have rather a breakfast bar, but we didn't win that one. We weren't able to have the bedrooms directly leading off the main living area, as I've seen in greenhouses in the United States, due to, we're told, Irish fire safety regulations. We didn't win the argument on signage either, although we managed to keep these to a minimum and in line with dementia recommendations. On the positive side, these houses are truly lovely. They're finished to a very high quality. We have lovely outdoor, if tight, outdoor spaces and lovely generous rooms. The food service is a combination of meals prepared at the household, with the main meal still being prepared in the central kitchen, as this is there's still a traditional nursing home on the same site. I was chatting with Seamus, the director of nursing, the other day, and he was telling me a story about one of the residents called Betty, who has advanced dementia, but still able to move around. She had a breakfast of porridge, which I think you might call oatmeal. She then got up and took her bowl over to the kitchen, washed it and put it away. This might seem like a very insignificant act, but it's something she's never done before. And it's one of the many transformational things that are happening on almost a daily basis within the houses. So the houses are running up now, are up and running and are bedding in. A critical success factor is the leadership team that are highly competent and are consistently reinforcing the values of the household model in a very challenging environment that, in my opinion, is still very risk adverse and heavily weighted towards a medicalised system. The direct care staff will openly admit that there are elements of the change process that have been very challenging. However, I do need to say, from the very outset, I could see that these direct care staff were full of love, compassion and commitment, and that remains the case today. As I mentioned, the regulator has been very supportive. And to date, the facility has not required any more staff than within the nursing home it replaced. However, the private sector, with justification, would say that the funding advantage that the public sector has does not allow for this model to be easily translated into the private sector. The second model I want to show you is a not-for-profit or social enterprise organisation called CARE in County Limerick, who interestingly are first and foremost a home care agency with no history of providing nursing homes, but its general manager, Colette Ryan, and its board were driven by the desire to provide somewhere where their clients, for their clients who for various reasons couldn't continue to live at home. Like all good innovators, they looked outwards and were particularly inspired by the De Hadjouet model in the Netherlands. CARP has done a fantastic job, I have to say, in terms of staying connected to the community, to their very good cafe restaurant that many of the local people use. The last time I was there were buggies and prams sitting alongside wheelchairs and walking aids, and it was just a lovely sight. I think the fact that the food is particularly delicious might be a big plus, but they've certainly achieved the goal of integration and breaking down barriers between the generations. In terms of addressing the thorny issue of home as opposed to home-like, this centre, I believe, have nailed it. They have 3 houses with 6 people living in each, using a relationship-centred care model, large private rooms, each with their own private garden, a lovely cozy sitting room with an adjacent kitchen where all the meals are prepared from scratch. And it's a lovely location, close to small town with plenty of space outdoors. In the context of sustainable funding, this facility has managed to demonstrate it can provide this care in a relatively similar way to traditional nursing homes. However, the cost care issues are still very much to the fore. The Irish Economic and Social Research Institute has publicly stated earlier on this year that the funding of nursing homes in the private and not-for-profit area have not kept pace with inflation, and that is a big issue. There's no doubt about it. As a not-for-profit, CARP received philanthropic funding to help them with the construction costs, again, which the private sector would say is an argument why this model is difficult to translate into a for-profit model. Third facility I'm showing you very briefly is another not-for-profit, albeit a much larger organisation. The reason I'm showing it to you is to highlight two key success factors. One was it was led by two amazing women, Norma Sheehan and Siobhan Grant, who had the vision and the determination to create the small-scale facility. And secondly, they did a retrofit from what I hope they do. I don't think they will mind me referring to it as a bog standard nursing home, and creating 6 households on a shoestring and embracing the butterfly model to underpin their practice. Again, like everyone else, they're struggling financially, but the evidence of the well-being and joy that you see when you go in there just reminds me of what is possible. And it's a place I love to visit, as the love and compassion just exudes from both the residents and the staff in such a palpable way. Again, their focus was on removing the clinical artifacts and creating a warm and inviting, relaxed environment. So now I'm going to go on and talk about the pandemic. If one thing connected us globally as a community in the past few years, it has been the awful experience that was COVID-19. My Aunt Bridgie, who was the last living sister in the photograph I showed you at the beginning of this presentation, succumbed to COVID in the local nursing home. There's no doubt the pandemic was a highly traumatic event for everyone, residents, relatives and staff. The mortality rates were deeply shocking. Residents who didn't have much time to spare anyway lost precious time physically and psychologically. And even today we're hearing harrowing stories of relatives being unable to be present with dying spouses and parents. My own cousin said to me, I'll never get over not being there in the end. And one of my director of nursing colleagues said to me, this was the worst time of my professional time, or of my professional life. Having said that, how awful it was, there was still some glimmers of positivity. In the process of developing bubbles, some staff related to me how the consistency and confines of the bubbles actually made their work more enjoyable, as they developed close relationships with the residents they were working with every day. I recall one director of nursing recalling how concerned the residents were for the staff and for the families out there, and how they tried to help and reassure them, reinforcing this concept of reciprocity that Dr. Bill Thomas highlighted in the Eden Alternative. Within the Irish healthcare system, there's a well-known disjuncture between the public and private systems, and that became better with a more integrated approach being developed. Technology came to the fore, with people pivoting very quickly, both in terms of relation to online healthcare and social connectedness. There was also a huge media focus, leading to the, coming from the major outcry, second major outcry, the only one I can recall other than the Lees Cross one. And it resulted, for a while at least, in a focus on long-term care, with a televised parliamentary debate, an expert panel who made recommendations for changes to the system, and funded research projects focusing on issues such as infection control and quality of life, and I'll come back to them shortly. And finally, because of the public outcry, there was political attention on the subject that is often sometimes very hard to get political attention on. On the 8th of May 2020, our Prime Minister went on the Late Late Show, which would be our equivalent to like the Saturday Night Live show in the US. And he said the following words: our model into the future was to build lots of new nursing homes, modern new nursing homes, single rooms, very high quality. Maybe that's not the right approach. Instead of having massive big nursing homes, maybe have smaller communities like we have done in the disability sector. A lot to think about. So obviously we were happy to hear that. And as I mentioned earlier on, there was funding for research was provided, and a key collaboration was established in Trinity College Dublin, led by Professor Des O'Neill, and Trinity House, which is a department in the university, which focuses on the intersection between the built environment, health and well-being, inclusion, climate change, and sustainability. The first phase of this research highlighted on the international level of a progressive environments in long-term care, created design guidance and focused on the intersection of infection control and quality of life. And the second phase is detailing case studies across the country and internationally, including the 3 I talked about earlier. This is especially relevant because Trinity House has acted as an advisor to the Department of Health in the development of the new draft guidelines, and in my opinion is another one of the key success factors in getting to where we are. So now I'm going to talk about what Marge probably wanted me to talk about most, which is the new government design guidelines for long-term residential care for older people. So the Minister established a multidisciplinary committee with all the various people being represented on it, and the guidelines were drawn up. As I mentioned before, Trinity House acted as an advisory capacity, which of course adds the importance of building on best international practice. And we're very grateful that that body of evidence now exists, because we didn't have it at our fingertips in the early 2000s. A consultation process has been enacted, and I understand 90 submissions have been received, which are currently being processed. My own input into this consultation process was in collaboration with Sage Advocacy, which is an Irish organisation focused on promoting, protecting and defending the rights and dignity of vulnerable older adults, older people and healthcare patients, and they're wonderful advocates in relation to older people in long-term care. So the key highlights include, what many commonly known elements of household models are that are understood internationally. That is that residents will live in households of no more than 12 people, although providers are free to go below that figure if they wish. There's single en-suite rooms. The household must have the ability to operate independently and be self-contained if required. I think that concept of self-contained households was always a principle of the household model, but I think it's really come to the fore as a result of the pandemic from an infection control perspective. So I suppose you could call that a win-win. Most importantly, the concept of residents having access to their own kitchen space is outlined. And I hope that this will help us move away from the highly risk-averse and segregated approach to food that we have, that has underpinned a reluctance to do this in the past. Other key elements I want to highlight is the requirement to ensure that there is an identified local need. That's really, really important, because here in Ireland, the tax incentive scheme, there was a tax incentive scheme for building nursing homes that came about in the early 2000s, as well as the more recent planning permissions for much larger nursing homes in larger urban areas have resulted in a distribution of nursing homes that's not always aligned with where people are actually living. So for example, when you look at counties such as Kildare, Dublin and Meath, which have the youngest populations, they also have the highest number of nursing home beds, while the west of Ireland, that have the highest proportion of older people, are areas that are most risk of nursing home closures. I presume some of this probably resonates with yourselves. So I think, I suppose just to finally say that the recommendation has been for no more than 84 residents in total, which is the equivalent to 7 households. So while it's very important, obviously these guidelines are very important and are very, very welcome, and they provide a very clear direction on where we have to go in relation to the built environment. That said, we can't ignore the challenges that currently exist and that have held us back in the past if we want to keep moving forward. Firstly, what countless researchers and change makers have said, environmental design is only one part of the equation. It's an important one, but without an overall transformation strategy that includes workforce development and training and more engagement with residents and families, we'll not see the major shifts in thinking and doing that we require. In relation to we can't ignore the elephant in the room, which is the current funding system, both in terms of the cost of care challenges, the disparity between public and private, and also the fact that we have a way of costing that does not take into account the savings to the acute sector or through less staff on turnover that have been demonstrated both in research within the Greenhouse Project and on this side of the Atlantic, as anecdotally reported to me by some of our colleagues in the UK. I've already mentioned the closure of small nursing homes, especially in the rural areas, which may need some innovation solutions to address the situation. And it's something that Sage Advocacy, along with some of the other NGOs, not-for-profit organisations, are focusing on. Another key challenge, which may be a bit provocative to some of our Irish stakeholders, is that perhaps we've got a bit too complacent in what we're doing practice-wise. The National Nursing Home Experience Survey I mentioned earlier showed that 90.3% of residents say that they had a good or very good experience. And that to me is a reflection of the deep commitment and caring of the direct staff that isn't in question here. COVID apart, and I'm not in any way undermining how awful that was for residents, we thankfully don't regularly hear about widespread abuse or poor quality, notwithstanding a few shocking situations in recent years. However, we know the world is rapidly changing, people's expectations and living standards have improved, and we now know that there's better ways of doing things, and we must take this information and do better. So, while there are challenges, we also have opportunities. Currently, there is a Commission on Care in progress in Ireland, and this provides us with an opportunity to raise issues and propose solutions in the Irish experience. In terms of momentum, a poll undertaken by Sage Advocacy last year in 2023 indicated that 81% of people that were polled agreed that the government should provide an innovation fund to promote small-scale household models of congregated care as alternatives to large nursing homes. There's no doubt we're going to have to consider the funding issues, and I think we need to do so collaboratively, transparently, and holistically. I also include into this mix the game-changing opportunity of technology. I kind of hesitated on putting this last point in, as the technology landscape is changing so rapidly, it's hard to keep up, but we definitely need a strategy to embrace its potential. So I suppose just to close off, I asked the question, what are the key issues that will help us to create sustainable change? As you've seen in this presentation, and it will be no surprise to this audience, inspirational leader is a critical factor, and creating and sustaining a program of change, particularly when the organizational issues are not all lined up, which they're not. We do have those people at many levels in the organization doing fabulous work, despite all the obstacles being put in their way. However, I really would like to see more innovation coming from, and I'm being provocative here, in particularly the top of the for-profit organizations. I know financial viability is a real issue, but two core elements of for-profit models, as I understand them, and I'm no expert, are innovation and risk-taking. Do we have to wait until we have every euro nailed down before we do anything? If we do, we'll have lost precious times for both older people and indeed for our future older selves. As we all know, hearing about the experience of older people who live in long-term residential care is a powerful tool of advocacy, and it's one that doesn't happen often enough. I want to introduce you to this wonderful book written by an amazing man called Tony Carroll, Cold Porridge, Broken Promises and a Missing Dog. which really gets to the heart of humanness and individuality of residents he came to know while working as an advocate in nursing homes. Residents' hopes, their dreams, and more importantly, their wish to continue to give to others, debunking the myth that extreme old age brings only helplessness and dependency. I can't underestimate how important it is to have governmental guidelines, both for providers and planners, giving clarity to the direction of travel and providing leadership to the system. However, as I said previously, it must become part of a wider transformation system if we're to truly achieve sustained change. There's a safe staffing exercise currently underway in Ireland, and I understand it's almost complete. In my view, it is critical that this gets nailed down as soon as possible in a similar way to the environmental design piece. From an Irish perspective, one of the characteristics we call ourselves out on is often having a plethora of policies and reports, but a poor record on implementation. So we really need to create an implementation and accountability framework that aligns with this work so that we can see if and how well we're progressing. As I mentioned before, this is a fast-changing world in which we need to be moving forward, creating opportunities for innovation. Two of the areas I'm keen to explore is inclusive intergenerational models, such as the one I had the pleasure of visiting in Denmark, called the House of Generations, whereby small-scale nursing homes were located within wider housing developments alongside students, and where the day centres for old and young were right beside each other, connected by pocket doors. Martin Ricks, the CEO from Belong in the UK, has related also to me how positive this intergenerational approach has been for their organisation. And I'm also very interested in the farming models, the green farming models in rural areas of the Netherlands. And finally, while we can contemplate the complexity of all these issues and the various positions and perspectives, it seems to me the only way we can move forward is together, trying to build a consensus and problem solving collectively around a shared set of values that put residents and our future older selves first. Coming together across countries like we're doing today, thanks to the wonders of technology, is to my mind a wonderful thing. I hope some of our experience in Ireland resonates with you, and that the sharing and learning from each other will help us all to do better on this journey. And as it's almost obligatory to end a session like this with an inspirational quote, here's mine. If you act like there's no possibility of change for the better, then you guarantee that there will be no change of the better. There will be no change for the better. So thank you very much for your time. And I've just put some references at the end there. Hopefully they're helpful.
So thank you so much, Anne. You've given us a lot to think about, and you've mentioned so many things that resonate with us, I'm sure, in Canada here, and some things that I think we'll be quite envious of in terms of what you said. But I'll touch on just a few things as people put their questions in the Q&A box that you'll see at the bottom of the screen there. You started the presentation talking about person-centered care and the language of it, and why it's widely used, but probably not implemented in terms of what it really means. And then you went into home and home-like, and I loved your example of Bertie, having the porridge and then going in and washing the dish and putting it away, because that's home. That's not home-like. That's home, which is obviously what we want to have in our innovative models. So you're able to do that in the home that you showed there. I guess the thing that came up with me too, as you were talking, was this whole issue of culture change, and how do you transform people to get onto the bandwagon, if you like, in terms of embracing this as a home, and how much value it has in terms of quality of life. I think you had a bit of a struggle with that, didn't you?
Yeah, we did, and I suppose the best phrase that comes to mind came from Steve Shields from Kansas in the UK. He used to say, you need to get on the bus, you need to go and see it and feel it, and go where somebody is doing it and see what that is like. So when we were doing our Drogheda project, we did just that. We went and had a look at some inspirational buildings, mostly, to be honest, within the learning disability field, who seem to be a good bit ahead of us. But I think bringing staff and bringing people to see how lovely it could be inspired them, and it gave people the enthusiasm to drive forward. So I think certainly, getting as much inspiration as you can from other people and learning from other people has been a huge bonus to us in relation to that.
And in terms of that, in terms of staff and so on, I was one point, I think you mentioned at one point about staff turnover. So I'm not sure what your turnover is like in those 3 homes you targeted, but do you have staff turnover? Do you have staff training? How do you hire? The staffing issues?
Yes, we do have turnover. And I think particularly after COVID, it's become increasingly difficult to encourage people into this sector. I think doesn't have a very good image. And I think that's the case the world over. And I think so we do struggle with that. And I know particularly in the public sector, we have a very high level of agency staff, which is really not where we want to be at all. But having said that, in one way, there's a lot of turnover, and at another level, in the public sector, we have we have better, more favourable conditions, working conditions, from a salary point of view and a permanency point of view, than some of the private nursing homes do. And indeed, private nursing homes would say the public sector rob all their staff once they've trained them up. So there are challenges. There's no point in saying there isn't. There is. But I do know that the staff in Drogheda, particularly, which is the one I'm most closely to, do feel valued and do feel that their worth is now being acknowledged. And it's always been there. And as I said, from the first day I went into Drogheda, the level of love and compassion and care that I saw was just so strong that it's wonderful to see them now working in a way that is still challenging in many ways, and they still, have to keep a very strong eye that they don't slip back into their old ways. But in general, I do believe that they would say that it's a much better place to be.
Good. You've mentioned, well, somebody has asked about the residents. So there's this whole issue of residents. Most of the residents in those 3 homes, are they all dementia residents, or are
in Drogheda? Yes, yeah,
yes.
and yeah, in fact, in the 3 centres, they're all dementia.
Yes.
Yeah.
But have you found, when you've done all your advocacy efforts and looked into the innovative models, have you found that these sort of innovative models could be for anyone, or is it just for dementia residents? Do you think it could be?
Absolutely. Oh, absolutely. And I think that's why I'm so pleased about the new government guidelines, because they're wider. They grew out of the dementia space, but very much what we need to see is that they would become absolutely for everybody.
Right. And in fact, here in Canada and Ontario, we actually have a transition ward that's a butterfly model. So for those patients in the hospital who are waiting for a long-term care bed are on a butterfly model of care ward. Yeah. You mentioned technology, and I'm curious to know what you found in your research and you're looking. What do you think needs to be done there?
Oh my God, I was hoping you wouldn't ask me that. Yeah, it's something I've been involved in over the last few years through some cross-border innovation projects with Scotland and Northern Ireland. And there's obviously, things like the most immediate things that come to mind are things like better remote clinical consultations and social connections for older, with families and with other people that have kind of emerged through COVID. But the more exciting stuff, which I think is coming down the line, is using the wearables that we all wear, for helping monitoring people's health in the nursing home. some of the very exciting stuff that's coming through in terms of robots. Obviously, aligning all of our clinical work so that we can take a lot of the drudgery out of some of the work that people do administratively. I think the key issue here is that we really need to develop a very good strategy. And, you know, there's been a lot of very good work in the Department of Health and in the HSE around technology in general, but I don't see a focus on long-term care in it, quite frankly. And I think we really need to have a ring-fenced long-term care strategy to help guide and support people. I mean, there's a lot of concerns about cybersecurity. There's a lot of concerns around, you know, moving too fast in the wrong direction. So I think we do need to make that much stronger than it is at the moment. And it's certainly one of the things that we have submitted to the Commission on Care as something that we feel needs to really get a good bit of attention to. Having said all of that, as I said, it's a rapidly changing environment, and who knows where it's going to be in 10 years' time, 5 years' time even.
There's, you know, COVID was dreadful. COVID was dreadful across the world for those living in long-term care homes. And what happened, from what I understand, for you in Ireland is, I mean, it was dreadful as well for you, but also there was opportunities. And what really struck me was you had the ministry on your side right after. Am I correct? And that,
yeah, absolutely. Yeah.
And they were very much in tune with looking at smaller households and so on. And we too in Canada had a COVID commission, and with many good recommendations. I think there were 85 of them, and one of which was small households. So there were other recommendations, which certainly some of them have been enacted. We struggle a lot with the government and with this. And I think what you're saying too in your presentation is internationally, we're all seem to be doing similar things, and advocacy can be improved and maybe enhanced if we all got together and shared the positives. Is that correct? Is that what you were?
Absolutely. No, I wouldn't want to give a false impression that we had everything sorted here. We don't. And I think, you know, the difficult conversations are only beginning to start in terms of really ramping this up and scaling it up. But I do think, you know, we are in a better place than we would have been a few years ago because of the wonderful, credible research that's been done in Trinity College. And, you know, as I said, the backing of the nursing inquiry and all of these things, they're all, I think they're all coalescing, you know, at a time which hopefully will make a difference. And I just think it's really important that we now all get the momentum there and keep it going and really, really drive this at every level in the organization. And I do understand that the challenges, say, for the private sector are very different from the challenges for the public sector. We have very little, as I said, not-for-profit. CareBright obviously is one of them, but we don't have enough of that. And we'd like to see a rebalancing of that model across the country. So there's lots of challenges for us there, but I am an optimist, and hopefully we'll be able to drive this forward together.
You mentioned research with Trinity College. In Canada here, very much of what we do is based on research and evaluation. And so you have some research, you mentioned that in terms of these models. Has there been a lot of evaluation through the universities on what's going on?
I suppose it's hard to answer that question. Yes, there is. Yes, there is. And as I said, there's a wonderful piece of research that has just been done in relation to safe staffing levels in long-term care, and that has been done by a number of the universities collectively. There was some work done, some pre-occupation evaluation done in Drogheda by Dundalk Institute of Technology, and as I said, the work that Trinity are also doing now. So yes, there is work going on all of the time. And as I said, I think when you start to pull it together, you start to get a more positive picture. But I think there is a general consensus that this is the way we need to go, and it is backed up by the science. And as I said, there's a wonderful body of international evidence now that wasn't there years ago, which is very, very helpful to us, you know. And I think where people used to think, oh, this is just a flash in the pan, it'll go away, and we'll move on to the next big thing. You know, there is a very credible body of evidence now, which is very helpful to all of us.
You showed 3 separate models of homes and based on innovative models around the world. And here in Canada, we look to it that this model of taking a larger unit and making it into smaller homes, if you like. So is that one of the options you might have been looking at too? And if so, you know, I guess the idea is like being home, we think of eating, we all eat, you know, and so we love communal eating, and that makes it home rather than home-like. Again, your example of Birdie. Is there any way in terms of what you've researched and what you've seen where you could take a large unit, make it more in smaller areas and still have that kitchen eating component in it?
It's a very good question, and it's one I have given a lot of thought to. How big is big, and what size should it be? I look at, you know, I think there's room for several different, you know, iterations of this. I would love to see some small scale nursing homes in small villages and towns, and I think the technology will help us to do that, in terms of, you know, remote support. I'm involved with an organization called Acquired Brain Injury. I'm on the board of it, and they have the most fabulous small houses in small towns all over the place, and to me is the perfect model. Having said that, I do understand that, you know, I'm always a pragmatist, and yes, I do think we can create small within big. I hope we don't do it too big, and as I said, I think these guidelines are pointing a direction which I'm very pleased about. So it can be done, and I do understand that there are greenhouses in the middle of, you know, high-rise apartments in New York and all sorts of places, but we need to do what we need to do in Ireland because it's a small country. So we really don't want to see too many very large nursing homes divided. I think the smaller we can get them, the better you know, for all of us. But I do think there are different options and different models that we can explore and deal once we get the ethos right and we get the principles right.
Yeah, I think probably a lot of this is driven by funding, which is what you mentioned in your presentation. And there's so much that you mentioned, and I know that this PowerPoint will be up on our website, or www.change long-term care now, and it will be on Family Councils of Ontario. So there'll be lots of questions and lots of discussion based on what you said. And it's really wonderful to be able to know internationally that you are there and you're doing all this great work, and we're all excited about what's going on in Canada. So thank you for taking the time today to share your experience. It's been wonderful. Thank you so much.
Thank you.
I'll turn things over now to Taeyang.
Thank you very much, Margaret. Thank you, Anne, for this wonderful webinar. Yeah, I just want to say thank you once again to CARP for organizing these events with us all throughout the year. And thank you, everybody in the audience. We had so many events this year, and we had always such an engaging and informative crowd. And it's such a pleasure for us to bring guest speakers to dive on different topics. And we are very pleased and proud to be collaborating on more events in the new year. So please make sure to subscribe to our e-bulletin, check our website for our winter programming. And I also want to mention that Family Councils Ontario is hosting our Fall Summit next Tuesday afternoon from 1 p.m. to 3 p.m. We will have a panel on bone health by Lisa Campbell from Ontario Osteoporosis and a discussion panel monitored by EPSIO staff. It is a free online event, and we would love to see you there. So I'm going to share the registration link in the chat, but it's also available on our website. And yes, as a reminder, this webinar has been recorded and will be made available on our YouTube channel next week. And the presentation slides from Anne will also be available with that. So thank you, everybody, for being present today. Thank you so much, Anne. Thank you, Margaret and Kathy. And I hope you'll have a great rest of the day. Thank you very much.